As a group of specialist facial therapists who all work closely with Facial Therapy Specialists International, the international charity that likes to educate facial therapists around the world, we realised that non-surgical rehabilitation of facial palsy varies globally. There's a lot of controversy around what is best practice, what should be included in practice and what should be excluded in practice. We therefore set out to develop a consensus about what should be included and excluded in the rehabilitation of adults with facial palsy, whether they're flaccid, paretic or synkinetic. So we carried out a two-stage study. Firstly, we did a nominal group technique to develop a questionnaire, and then we carried out a Delphi study. And we recruited our participants worldwide through an experience-based inclusion questionnaire. And we were looking for expert facial therapists with a lot of experience in the field of specialist facial therapy. So our final Delphi questionnaire that we set up had 166 items included and covered assessment, outcome measures and interventions such as education, eye care, neuromuscular retraining and electrical modalities. And we set our agreement at 80% to indicate participant consensus, and any items reaching 70 to 79% were deemed as nearly included or nearly excluded, because we wanted to have a really high level of agreement for this consensus so we could be really sure about the expert agreement on best practice for specialist facial therapy. So when we averaged across all the presentations, we ended up with 25% of the items being included, and we'll go through those in a little bit more detail. So we know that facial therapy improves facial function, facial expression and quality of life for people with facial palsy. But historically, facial therapy has been provided by generalist therapists who haven't had any specific postgraduate training about the unique facial neuromuscular system or what facial treatment methods are particularly effective. So they've tended to use non-specific and ineffective techniques such as gross facial exercises or electrical stimulation, and a lot of those techniques continue to be used inappropriately today. So specialist facial therapists do a lot of postgraduate training, and that really works to emphasize the significant differences between the face and the rest of the body. So we really know that it's important patients get specialist facial therapy rather than general therapy, but we really needed to hone into what the optimal methods of that are. There is already studies out there that conclude that facial therapy improves function in patients and reduces sequelae in acute cases. And these findings have been strengthened by recent systematic reviews and randomized controlled trials. In particular, a retrospective review recently showed that patients who receive therapy within the first 2 years post-onset display less synkinesis and better physical recovery scores than patients seen later when they receive specialist facial therapy. So again, it's about detailing what that specialist facial therapy intervention should include. So we ended up with 49 expert facial therapists from across the world taking part in the study, which was a fantastic response, and we're very grateful to all the specialist facial therapies that gave up their precious time to take part. We had 2 rounds of the Delphi study before we had our final results. So if we look at assessment and outcome measures, there was 43 items in this category, and the only ones that were included across all presentations were use of the Sunnybrook facial grading score, use of photographs and videos, use of palpation, and also the idea of working with psychological therapists, if they're available to people, was included, which was great to see. In the synkinesis group, the Facial Disability Index, the Facial Clinometric Evaluation Score, and the Synkinesis Assessment Score were also included. So a lot of the assessment and outcome measures were excluded. For example, using computers to do quantitative assessment and eFace and FaceQ were excluded. It was interesting that the Facial Disability Index and the Facial Clinometric Evaluation were both included, and whilst the FDI scale has been in use longer, we're recommending use of the FACE scale because it demonstrates statistically significant changes more reliably over time. Recent guidelines also demonstrate the association between facial palsy and psychosocial distress, and state that all health professionals should be able to provide basic psychosocial assessment and screening and advice and referral. So we were pleased to see that liaising with psychological therapy colleagues was included, but was surprised that a psychosocial score was not included, and we would therefore recommend that therapists build their confidence in using a psychosocial score, and we recommend the Core 10 as a simple, license-free, valid and reliable psychological measure that's quick to use for adults. We weren't surprised that computer-assisted quantitative assessments like Emotrix were excluded because they're really not practical for quick implementation in a clinical setting, but that's certain to change as access to different technology changes over time. So in terms of patient education and eye care advice, nearly 96% of the education items were included, and this was the highest rate of any category, showing how important education is for this patient group. So, for example, educating patients about normal movement patterns, their facial muscle anatomy and physiology, the way the facial nerve gets injured and the way it recovers, types of diagnosis and what the prognosis for their condition might be were all included, as was being able to signpost patients to psychological support resources, clearly explaining the treatments that you're going to use with your patients before implementing them, and giving out advice regarding all aspects of eye care, of which there's many. And there was no exclusions in this group at all. And we felt that the fact that patient education was so clearly important to specialist facial therapists was especially relevant given the prevalence of inaccurate and inappropriate advice that's given from non-specialist clinicians in the online community these days. We also noted that although oral care recommendations were not included in our study, there has been a recent article outlining the impact of facial palsy on oral health, which recommends simple strategies for reducing the sequelae on the oral health of facial palsy patients. So moving on to treatment options. With eating, it was included to recommend that patients take small bites whilst they were eating to make it easier for them to eat. In terms of their communication, encouraging people to slow their speech down to ensure their speech is intelligible was included for flaccid and synkinetic patients, and across the board it was suggested that patients should not suppress their emotion when communicating, as that can impact their mood. Taping was included in the flaccid presentation for eye closure and lower lid support. And when we talked about increasing symmetry of the face, reducing overactivity of the unaffected side of the face was included throughout, and in the flaccid stage, contralateral soft tissue stretching was also included. With regards to chemodenervation or botulinum toxin, ipsilateral chemodenervation, so injections to the affected side, were recommended for synkinetic patients, and respondents all agreed that facial therapy should always be initiated before chemodenervation, and that is also supported in the literature. And the reason it's felt so strongly that therapy should start before botulinum toxin is that whilst injections can reduce hyperactivity, they can't stretch contracted muscle or retrain appropriate cortical motor control. So in poorly educated patients, botulinum toxin has actually been seen to reduce compliance then with exercise programs, whereas in a well-educated patient, it can be a highly effective adjunctive treatment and may even further enhance learning. Interestingly, the only modality included by consensus in paresis and synkinesis was facial neuromuscular retraining, which is an all-encompassing method of facial retraining. It's appropriate that it's not included in flaccidity because you can't retrain facial movement when there's no innervation to the facial muscles. And we were surprised that mime therapy didn't reach consensus because mime therapy really is extremely similar to facial neuromuscular retraining, but it's just perhaps more geographically limited in terms of nomenclature, so may not have been recognised in other locations. Multiple therapeutic modalities were excluded by strong consensus, including electrical stimulation, ultrasound, and laser. So really, if people want to use these tools, then they need to carry out high quality research in those areas before utilising those tools. And items such as growth strengthening, gross movement training, resistance training, gum chewing were all excluded, even though they're commonly recommended by therapists without specialist training. And they're very contradictory to facial neuromuscular retraining, which instead uses precise coordinated movements. In terms of self-administered rehabilitation techniques that were included, then eyelid stretching and manual blink were included for flaccid patients. Massage was included across the board. And then for synkinesis, relaxation was included, touch biofeedback to inhibit synkinesis during movement, and also movement pattern retraining using the unaffected side as a model for the affected side, and incorporating emotion into movement to improve movement and visualization, as well as doing soft tissue mobilization, stretches, and trigger point releases. Because each patient's unique, it was no surprise that provision of a documented, individualised home rehabilitation programme was included for all patients across the board. So just like surgical interventions can't be standardised, facial therapy also must be individualised to address each person's unique physiology, recovery, psychosocial response, their cognitive abilities, their learning style, and also, of course, their personal goals that they want to achieve. In addition, the majority of facial therapy is carried out by the patient at home on their own. So the use of home programs is really imperative, as was indicated in our results. So overall, our notable inclusions were the simple assessment tools like the facial grading score, the facial clinometric evaluation, patient education, treatment using facial neuromuscular re-education, individualised training and individualised home programs, and many treatments commonly used by general therapists, non-specialists, were excluded. For example, growth strengthening exercises, resistance training, electrical stimulation, and many other modalities. So this consensus study really highlights areas in the specialist facial field that need further study to improve our evidence-based practice. But it's a first step towards bringing together the global community's expertise to establish best practice in facial therapy. And it's hoped that this study will guide clinical decision-making, advance research in this field, and optimise our patient outcomes in this challenging field.